My name is Lacy Haefli, and I am a student at Grand Canyon University. Today, I'm going to be talking to you about malaria, specifically Plasmodium. So, our objectives today include defining malaria and identifying the causative agent. We should also be able to identify key developments in the history of malaria, then describe the taxonomy and structure of this disease, describe the pathogenesis of malaria, the epidemiology of malaria, and then explain the treatment and prevention of spreading of malaria. So to kind of give us an overview of what malaria is, this is a common parasite from tropical and subtropical climates, and it is spread from infected mosquitoes. In 2020 alone, nearly half of the world's population was at risk of malaria. And it is responsible for infecting approximately 290 million people a year and killing roughly 400,000. African regions were home to 95% of malaria cases, with 96% of the malaria deaths. Of those, children under the age of 5 accounted for approximately 80% of all malaria deaths in that area. When a person has malaria, they experience a variety of symptoms. So this includes fever, chills, headache, nausea and vomiting, diarrhea, abdominal pain, muscle or joint pain, rapid breathing, a rapid heart rate, and a cough. People will also have what are known as malaria attacks. These attacks start with shivering and the chills, which eventually lead to a high fever and then sweating. Eventually, the person's temperature will begin to level out. It can take anywhere from 7 to 30 days for symptoms to appear, but depending on the parasite species that infects you, signs of the illness may actually not appear for many months after exposure. If a person does have some immunity to the infection, the symptoms may be less severe, or they may not have any symptoms at all. Children under the age of 5, pregnant women, and those that have HIV and AIDS are at higher risk for contracting malaria. So the story of the discovery of malaria starts in 1880 with Alphonse Laverne. He discovered the parasites in the blood of one of his patients. It wasn't until 17 years later that William McCallum discovered the sexual stages of the parasite. He found these in birds that were infected with a related species, the Hemetoproteus columbae. Um, Along with this discovery, Ronald Ross in the same year also observed the whole transmission cycle of the parasite Plasmodium relictum in Culicin mosquitoes and birds. A year later, in 1898, an Italian malariologist team actually conclusively determined that the Anopheline mosquitoes transmitted malaria to humans. Through the work of Henry Short and Cyril Graham, they were able to show that the malaria parasite actually develops in the liver before where it then will enter into the bloodstream. They also saw the development of the final stage of malaria in 1948. However, their findings were not conclusively confirmed until 1982 by Krotowski. So, all of the types of malaria that infect humans all come from the genus Plasmodium. So there's multiple species that do infect humans and cause these symptoms that we see, including Plasmodium malariae, Plasmodium falciparum, and Plasmodium vivax. So they do have a sturdy cytoplasm, and when stained, you will see a large chromatin dot in the center somewhere in there. The trophozoites of this have a compact cytoplasm with a large chromatin dot and will occasionally actually form bands. Schizons will have anywhere from 6 to 12 merozoites with a large nuclei clumped around a mass of coarse, dark brown pigment. The gametocytes will appear round or oval with a scattered pigment throughout. And the structure of these are morphologically kind of indistinguishable with a highly structured array of merozoite surface coat proteins within their cytoplasm. Knobs are present in the membranes, and there is evidence that this is where proteins are transported through their surface in the intracellular parasites. So the pathogenesis. So there, with all of the varieties of Plasmodium parasites that there are that infect humans, they are all spread through the bite of infected female mosquitoes. So this happens when they feed on humans to nourish their eggs by injecting sporozoites into the bloodstream of the human. So these then get taken to the liver, where they mature into schizons, where they multiply thousands of times into the merozoites. The merozoites then leave the liver and get back into the bloodstream, where they begin to invade red blood cells. So the plasmodium modifies the surface of the infected blood cells and can actually create adhesive phenotypes. They then grow and divide, and as they do this, they destroy the blood cell and actually cause it to rupture. Most of the merozoites reproduce asexually, while others, called the gametocytes, will actually reproduce sexually. And so this particular type will mate when they are actually in the gut of a mosquito that has bitten an infected person. So when they mate, the gametocytes, they form eukaryotes, which are the embryos, and they then embed themselves into the gut of the mosquitoes, where they will then mature for 9 to 14 days until they turn into oocytes. So they then will break out and release thousands of sporozoites, which travel to the salivary glands of the mosquito. This is where they then, are ready to be infected into the next person to start this whole cycle over again. So the tropical and subtropical regions of Africa, Central and South America, Asia, and Oceania is where malaria primarily occurs. So there is a huge variation in the amount of transmission between these areas and the risk of infection. So when estimating the impact of malaria, it is important to look at transmission intensity, the level of immunity within the population, and the manifestations of malaria illness. So actually, areas with higher levels of immunity also typically have the highest transmission rate. So this is going to be where we see in red on our map here. So generally, the first time a person is exposed is early on in their childhood, with repeated exposure throughout their lifetime. In areas where intensity decreases, so does population immunity. So that would be the yellow areas. So what this means is that illness is more frequent amongst all age groups. Um, in the displaced populations, the blue of our map, they are the highest risk for severe illness and death due to there being no acquired immunity. So treatment options. So when a person does contract malaria, there are a couple of different options. There are chloroquine phosphates and then artemisinin-based combination therapies or ACTs. So chloroquine phosphate is the preferred choice for prevention and treatment of malaria. This anti-malarial drug is taken by mouth with a dosage and length of treatment depending on the severity of the patient's condition. However, when it comes to children, they do also base this on their weight. Unfortunately, this medication is also one that in many parts of the world, the parasite has actually started becoming resistant to. And so, unfortunately, the drug can no longer be used effectively. Um, ACTs kind of help pick up that slack. So, they use a combination of two or more drugs that fight the disease differently. So again, this is generally used when chloroquine phosphate resistance is present. So if a person does not get treatment, it can cause serious health problems and even death. And so it is important to seek treatment right away. Getting the right medication and correct dosage can treat malaria and then even clear the infection from the body. So how do we prevent this? Well, one of the most important components of malaria control is vector control and elimination strategies. So the methods that they do this is a couple of different things. So one thing that they can do is insecticide treated nets. So we can see the image here of this young man who has an insecticide treated net and they put it over their bed. And this helps protect them at night from bites. And then they can also do indoor residual spraying. So what is that? Well, indoor residual spraying involves the coating of walls and other surfaces of a house with a residual insecticide. So this is effective for several months and works when the insects come into contact with the treated surface. This does, however, not directly prevent bites, but does instead kills them after they have fed when they go to rest on a surface. To be effective, though, it must be applied to very high proportions of households within an area, and that should be roughly of 80% of households. Another method of vector control is through environmental modification. So this includes the draining and filling areas where pools of water can accumulate to stop the larval stage, or even using larvicides. So mosquitoes, when putting their eggs, they fertilize them in the standing water. So getting rid of that standing water or using of larvicides just kind of stops that process from beginning. Fogging or area spraying are used when an epidemic has broken out in an area. These, however, do need to be done during the peak time of adult mosquito activity because it is more difficult for the insecticide to reach resting mosquitoes. Another method is preventative chemotherapies. These also just help to prevent malaria. It's also important to use vaccines like the RTS, SASO1 vaccine amongst children that live in areas with moderate to high rates of malaria transmission. Another easy way to kind of help prevent the transmission of malaria is protective clothing. So wearing longer sleeves, wearing pants, even just using bug spray, screens on windows, and doors of that nature as well. Here is a list of my resources, and I hope you enjoyed this presentation. Thank you so much.